Many of you may wonder, why do we bother taking and putting together 6 hours of material, which, by the way, started out as 10 hours of material. We eliminated 2 hours because we figured it was sort of superfluous. But then we got it down to 8. Now we've crammed 8 into 6. And why are we doing it when, as most of the people in the industry are saying, we don't really know enough about where PPACA is going? PPACA is the acronym for the Federal Health Care Reform Act. But we do know that this act is like watching a great big tractor semi-trailer. You're standing there and you're watching and you're saying to yourself, I'm not really sure where it's going to go. And then you realize it's completely out of control, speeding like crazy, and you're looking right into the headlights. You know where it's going to go. Yeah, that's where this law is. There are pieces of it that are coming right at us, and even if we don't know the exact moment it'll hit or what the squeal of the tires are going to sound like, we know where it's going. And that's what this program is all about, to try to give us an idea of where it's going and what we can do about it today. Not politically what we can do about it, what we can do about it for ourselves to build a better business, what we can do about it to help our clients. The first thing you got to remember is this, PPACA, was named after a lovable animal from South America. It's about this tall, and they make sweaters out of it. Yeah. Well, I think that's what they must have thought they were going to try to do, sort of make it comfortable like an alpaca and get you used to it, right? The problem is they picked the wrong kind of animal to make it on, because those of you who know anything about alpacas, they spit like crazy. Yeah, this one does too. Yeah. This is the kind of law that absolutely proves the old adage that you should never underestimate the power of stupid people collected in a large group like Congress. You know, that's really, that's the deal. What does it stand for? Patient Protection Affordability Care Act, PPACA. Yeah, its goal is to transform both health care and how we pay for it. And by the way, in and of itself, if that's the goal, and I took everybody from the most conservative person to the most liberal person and said, is that a worthwhile goal? We'd probably all agree. I mean, think about it for a moment. If our system, our industry, the insurance industry, does something inappropriate to one of our clients, doesn't pay a bill, doesn't get somebody a referral, doesn't get them to the right hospital, whatever it may be, and the customer gets harmed in any way or even discomforted, who gets fired? You do. Every law we've ever passed in California that has helped the carriers to improve their own operation inherently improved the conditions for the consumer, and that improved our lives. So we're not here to argue about the goals of the program, because the goals are admirable. It's also simply one more step. A lot of people think this is a major. The major step was, of course, mandating that people buy it. That was a big step. But in and of itself, government involvement in our health care has been going on in a big way for a long time. We're already affected by it. For example, way back, 1965, Medicare and Medicaid was set up. That literally transformed the payment systems of America and directly impacted the private carriers and how we negotiate with hospitals and with doctors. 1973, the Federal HMO Act was established for nonprofit HMOs, and then in '79, the act was changed to allow profit. And in California, we saw it. We saw the FHPs go from nonprofit to profit and then get sold to Take Care and United and all sorts of things. Pacific Care was in there somewhere. We saw Blue Cross move from a nonprofit operation to a WellPoint profit operation to eventually part of the Anthem profit organization. So direct effects by these laws. 1974 was ERISA. Those are the rules that basically set up how the employers have to treat and protect their employees in terms of retirement and security and all that sort of stuff. And that law has gotten bigger and bigger every year. 1997, what we call CHIP, or in California we called it Healthy Families. In 2003, Medicare Part D produced a new product line for us to work with. And of course, 2010, PPACA. The goals of all this activity are based upon a basic promise. We want quality, affordable, and portable health care. I don't think anybody would disagree with that. When we go out and have to deliver a 22% rate increase because the medical cost factors are simply going up like crazy, all of us do agree, maybe we should get some control over the medical care system. So that's a good promise. Lower medical costs, that's a great promise. Guaranteed acceptance, well, in California, we have that at many different levels already, but in lots of other states, they don't have that. So that's a good promise. Minimum comprehensive benefits. We all agree with that. If you're going to buy a health insurance policy, it should cover at least some minimum standard to be qualified as insurance. There's no doubt on that. How about subsidies? Well, subsidies are a little tricky question, but is there anyone who would say, I want to take every poor person, every genuinely poor citizen in California, just throw them in the street, give them no support at all. Do away with Medicaid, for example. No. You would? Oh, okay. He's a meanie. But generally, we have enough of a Judeo-Western Christian philosophy within our governmental systems to say, yeah, the poor of us probably should be helped. So subsidiaries is not bad. A national exchange, heck, we got an exchange right here in California, sitting right up in this building. CalChoice. Now, we called it back then a HIPIC, a health insurance purchasing co-op, and the state put one in too. And we competed even, Steven, with 2 HIPICs in this state until the private market won. Exchanges can be a good thing if run properly with the right rules. Yeah, that's not bad. Private marketplace, we obviously all want that. Reforms in Medicare, yeah, there needs to be reforms in that area. Mandatory enrollment, that's where we all get a little separated on the political spectrum. So there's some question about whether that should be a goal per se. State flexibility, we certainly want that. But what did we get? Think of it this way. Here's some goal. I want to build, think of the goal as a piece of machinery. I'm sorry, as a product. And I want to build this product, okay? Now what I got is I got a thing called PPACA. It's the machinery that builds the product. Got the visual image? The problem was it didn't get built right. It wasn't that we disagreed with the goals, it's that the machinery aimed at making that product was such that sometimes it's sort of built something over here. And in some occasions, like the goal is to get affordable health care, it turned around and went 180. It's actually increasing the cost of health care. So it's not the goal or what we're trying to accomplish, it's the machinery built that is the problem. I mean, think about a workforce. You got one man in the workforce, and he's sort of a useless worker. And he's building this machine to produce this product. One useless worker is a shame. Now take 2 of those useless workers, put them together. You know what they are? A law firm. Now, 3 useless workers or more, that's a Congress. There you go. Now you got what happened. You got this machinery built that is just, it's good intended. It's just not the right way. And what happened was the political considerations, the infighting became that somebody on one side was going to build a machine no matter what it produced, and it was simply inconsistent with the goal. In many occasions, we're working desperately to try to fix parts of that machinery. In other situations, in small ways, we've turned off parts of that machinery. And of course, there are other people that are trying to do away with the machine altogether and say, admire the goal, rebuild the machine. But we have to work with what we have. We have to recognize that decisions are coming out every day from the Health and Human Resources, IRS, Department of Labor, National Association of Insurance Commissioners, state regulators. They're all tinkering with this machine. They're tinkering because they've been given the job to tinker with it to try to achieve those goals. And we are being influenced by all those collective decisions, so we've got to go ahead and prepare as those decisions are permanent, even if tomorrow that whole machinery gets taken away. If we don't prepare, then we're right in the headlights of that semi. Got to be prepared. So that's what we're going to do. PPACA sets the goals and allows enough variation from state to state that in California we're going to have some differences in other states, and we're also going to learn to work with them. What's been done so far? Now I'm going to go through this very quickly because grandfathering, lots of stuff been done. We're going to cover that in depth in the 2nd course. Second thing, small business tax credits. We're going to cover that actually in the 4th course. That's a typo up there. It's in the 4th course. Medical loss ratios. We're going to cover that in the 6th course. That's the one that a lot of us think is going to dramatically affect our commissions, and it may not. Preventive services. We're going to cover that in our 2nd hour today. Today, in this course, we're going to talk about dependents to age 26. We're going to talk about annual limits for essential benefits. We're going to talk about mini-med programs, limited medical plans, where they fit into this thing. We're going to talk about external and internal reviews. We're going to talk about rescission restrictions of this act. We're going to talk about retiree insurance programs, temporary high-risk pools, and we go on. We'll cover state-based waivers. And let's see if this thing goes. Voluntary payroll deductions for long-term care, and then finally Medicare changes. So, given that the first thing we said we're going to talk about is dependents age 26, many of you may already be aware of this, but there may be some features that you're not aware. So let's go through that. First, what's it say? If an employer offers dependent coverage, any child can come back onto that plan up to age 26. Any child. Okay? That child can be biological, stepped, adopted, foster children are included. Now, what that simply means is, you can imagine, if I've got a son who lives in another state, he is earning $100,000 a year, but for some reason my health care plan is cheaper at my work, he has the right to come back onto my health plan. His residency, his tax status, dependency on tax status, whether he has coverage or is even eligible for coverage, none of that matters. He has the right to come back into the system. However, this does not include grandchildren, does not include custody arrangements, and does not include children of domestic partners. The reason for that is the federal government PPACA Act stayed within what was known as the Federal Defense of Marriage Law, and like in COBRA, domestic partners are not eligible for federal COBRA. Here in California, of course, we have CalCOBRA, which is where they go on the domestic partner situation. But the age 26 dependent category is not applicable for domestic partners here in California. Okay? The adult child may elect whether eligible on their own plan or not. Eligibility to some other plan is not relevant, but here's the one exception. And everybody, when we get to the grandfathering class, everybody says, what's the big deal about grandfathering? If you're a grandfathered group, you can test to determine whether that dependent trying to get back on your plan is eligible for coverage on another employer-sponsored plan. If he's eligible, you can deny his access to the plan. And by the way, think about how much money that saves the grandfathered group. You got a whole bunch of kids who are 24 years of age. Do the healthy ones come back onto their parents' plan, or do the sick? You got it. So if you have any way to sort out who can get back on. By the way, as we go through this, you see there's also lots of exceptions for the grandfathered group. And I want you to start thinking in the term grandfathered group, not grandfathered plan, because there's a big misunderstanding between those two things, and we'll get to it in the second hour. What else do we know? Well, tax dependency, student status, marital status, place of residence does not affect their rights to come back onto the plan. It may affect their right to ability to get onto a plan in the sense that it's a Long Beach only HMO. But that's the one exception. If the carrier has licensure or has some opportunity to cover someone as far away as New Hampshire, then they get to come back in, even if they live in New Hampshire. Simple as that. Okay? The employer has a requirement to notify the employees of this right. Okay? Employer has a requirement to notify. So that's going to become part of that typical thing we hand out every year that talks about you have a COBRA right, and you have family leave rights, and you have these rights. Just another addition to the big poster you put on the wall. Got it? Open enrollment, obviously, in qualifying events, all the same for that dependent. So the dependent has just like a COBRA guy. If I'm a COBRA person, I'm not working in the company, but I get all the rights that you do. If you get a right to change to a new company at open enrollment, so do I. Okay, simple as that. All the same rights. No difference. COBRA does apply. Now, the law says you're in till age 26. But as you can probably figure out, if I voluntarily leave a plan at age 26, I get COBRA. That could be an 18-month event or a 36-month event. So it's conceivable you could have a dependent on the group plan up to age 29. Wow. So not having those dependents, if you're grandfathered, suddenly means, hey, I might save some money in this thing. Another thing that came into effect last September was what we call annual and lifetime limits. Basically, starting in 2014, there are no limits on essential benefits. We'll talk about that in a moment. No limits. When we say no limits, we're talking about it being slowly phased in. We didn't see much of a reaction in California because most of our HMO plans, the HMO plans which most of us are in, have a no limit already. Many of the PPO plans, in order to stay competitive in our marketplace, had either no limits or $5 million kinds of things. But you had some states in the country, like Maine in particular, where about 60% of their plans had a limit of about $750,000. You know, then you had little quirky things like our Mr. Mib, where it was $75,000 given in a year. That kind of limitation. So what they've done is this. Last year, The phase-in number was everybody got at least a $750,000 limit. You know, this year it's 1.25, 2 million, and then of course by 2014 unlimited. Now you can have day, visit, and frequency limits on certain kinds of non-essential benefits. Okay? Since we're going to talk about essential and non-essential later, just think of it this way. If you've got somebody who has a benefit on a chiropractic visits, and their visits are 2 visits a month, that's what's in the policy, that would still be allowed under PPACA, if it's determined that chiropractic benefits is non-essential. Now, if it turns out it is essential, then it has to go to unlimited. Okay? So you're still going to have those simple kinds of limits that we typically have today. By the way, this business of non-limits applies to both in and out of network. In and out of network. Waivers are possible. In other words, a carrier, such as the major carrier they have in Maine, went to the state legislature and asked the governor of the legislature to apply on their behalf for a waiver, so Maine was given a waiver not to have to force these upper limits for a few more years. There will be limits allowed on non-essential benefits, like we said, day, visits, frequency, or there may be dollar limits that are going to be allowed. But because we don't know the details of essential, but I'll give you the broad brush in a few minutes, we don't know the details on non-essential either. But they'll be coming out. But logic will give us pretty good idea. A benefit may be excluded totally. In other words, let's take autism. There's big fights about whether autism should be in a policy or not be in a policy. Right now, as of this exact moment, this is not a mandatory unlimited lifetime benefit on autistic care. If the business of essential benefits declares autism to be an essential item to be covered, then there would be no limits whatsoever on it, and it would have to be included in the policy. But if autism stays where it is right now, I could write a policy that says my benefit for autistic care is nothing. Now, I use autism because there's a lot of fights as to which way it will go. But if we use our logic, we know full well cosmetic surgery is not going to be an essential benefit. So I could put it in as a non-essential, I'm sorry. We could put it in as a non-essential benefit if we wish, but likely what we're going to do is exactly what we do today, which is cosmetic surgery simply isn't covered. So you can exclude certain kinds of coverage. The key will be in the definitions here and here on essential. Okay? What are the essential benefits? Well, as of this moment, it's not determined. It's expected out any moment. Right now, a carrier and a self-insured plan have to operate with what's known as good faith compliance. If they're called on the carpet at a later date, the good faith compliance is going to be the question. What would be an example of a non-good faith compliance? Somebody preps his self-funded plan for the PPACA by declaring that hospitalizations for maternity is a non-essential benefit. You go, wait a minute, that just defies all logic, every sense of decency. That would obviously at a later date be declared simply not a good faith compliance. But take autism. Is it good faith compliance right now to not include that as an essential benefit? Yes, because most of our policies don't include that. Okay? So that's sort of the standard you can work with. It has to be reasonable, it has to be consistent. What a carrier did last year or the year before would be a standard by which they would be judged until the final regs come out. Okay? What else we got on it? Generally, they're defined as this. This is why I say we have a pretty good idea. When you look at this list, what you're going to see is what a typical California HMO has to supply under the Knox-Keene licensure, which we work with every day. So in our state, we're probably not going to see a lot of differences in this. But in other states, yeah, we still got states out there that literally allow the employer to buy policies with maternity optional. But we just don't even have that in this state, as an example. So what do we got? Ambulatory emergency services, hospitalizations, maternity and newborn care, mental health and substance abuse, prescription drug, rehabilitative services and devices, laboratory services, preventive and wellness types of opportunities, pediatric services including oral and vision care. Not anything too surprising in there. If it stayed in sort of where the field we're at now with what our HMOs typically look like in California, probably not make a large difference. Where people get concerned, I was on a panel in Alaska, for example, and the Alaska governor is fighting this thing tooth and nail. Because, for example, as was demonstrated in the panel, what if it's decided that methamphetamine rehabilitation is an essential benefit? What if it was decided? It's not right now. Unless it's your kid, then it's pretty essential. But yeah, but if you ever known anybody with the problem, I mean severe meth head problem, you can literally have that person go through 4 rehabilitations in a year. Now let's assume that that rehabilitation, part of it was hospitalization, since hospitalization is an essential benefit. You're looking at a state in Alaska that perhaps a meth head has to be put into a hospital up to 4 times a year for treatment, and you've only got 3 cities that can handle that: Fairbanks, Anchorage, and Juneau. And you got a whole bunch of people that aren't even close to those cities, which means air vac to the hospital. And if you have ever lived in Alaska, you discover the air vac cost is approximately, on average, $6,000 one way. So you're talking about a $12,000 round trip, 4 trips a year, $48,000 plus the cost of the hospitalization for a meth rehab. And you can imagine what the price inflation would be in the state of Alaska. Huge. You have to be uncontrollable. You put in autism, who knows what that will cost? I mean, that's a very sticky subject. So that's where the fighting is going on. What we need to take away from it at this point is to assume that reasonable people are probably going to look at things like California and use us as a model. And I'll tell you why. If you go to states like Maine and Kentucky and Tennessee, and you say to those people, here's our standard HMO benefits, they're going to go, wow, that's a rich plan. Because in those states it is. When you consider that the government has to probably work with the least common denominator and try to raise those states up, we're already at the top when it comes to mandatory benefits and things we have to do. So I don't think we're going to see a lot of activity in that area. Okay? So I think we're probably going to be pretty good. What about mini-meds? People thought, well, mini-meds are not possible. Yeah, they are, but the key distinction is they need to get a waiver. In other words, a state like Maine asked the federal government and got a waiver to keep all their mini-med plans, because when we talked about that $750,000 limit they have there, 60% of their people are on that type of mini-med limited benefit policy. So a state can apply for the mini-meds. Obviously, a mini-med that meets the currently phased-in levels can still continue to sell. We have a situation in California where, at least for the moment, the insurance commissioner is probably not very fond of mini-meds. So the probability of mini-meds staying in our market becomes probably pretty remote as we move closer and closer to 2014. So that's something we can be prepared for. Now, why might he go after a waiver? Think about our agricultural industry in California. If we have to go full unlimited coverage on the essential benefits for every migrant worker in the San Joaquin Valley, that might literally take the price of a tomato up to about $25 a tomato. So the governor may basically say, hey, for certain industries, we've got to do something about this. You've already seen it if you read the paper. There's about 500 corporations in America that basically said to the White House, if we have to go to the 750s last year and 1.25 this year, we're just going to drop the health care because we can't afford to do it. The McDonald's of the world and the Walmarts and all those. So about 500 waivers were given to very large corporations because the goal is not to get people uninsured. So the waivers are out there, and we'll see where that goes. Waivers have to be accepted, obviously, by the plan sponsors, by the insurers. Waivers can be granted. Lifetime limits can be changed. Whatever it is, basically a state can apply for a waiver on anything. A company can apply for a waiver on anything, and they've been doing so. So we're not out of the woods. The Office of Consumer Information and Insurance Oversight of the federal government is the one that makes that decision, just for the record, so you know who to call if you ever want to call somebody. Appeals process. We already have embedded in our state law internal and external appeals laws. So this part of the act really just didn't affect us at all. Nationally, it affects some states. And if you're a grandfathered plan, you don't have to put in the internal and external appeal. So again, you have a small cost savings in your health care. Notifications, you have to notify the employees about this process. The notifications have to be cultural and language specific. Obviously, here in California, we have no problem with that. We have every cultural language you can cover. So we're in pretty good shape. The rest of the country, maybe not. The external appeals process can be based upon either state or federal law. We already have it in our state law, so no change for us. Coverage rescissions. We have very strict rescission language in our law already. It's extremely hard to rescind somebody's coverage unless a carrier can literally prove outright fraud, willful intent, and all that sort of stuff. Same thing applies in terms of the federal law. Prohibition except for fraud and intentional misrepresentation. They tweak it just a little bit more with one thing. They say rescission or adverse benefit determinations are subject to appeal. So you understand that language. There are apparently some carriers in some states that might say to Dennis, Dennis, you didn't tell me about your cancer. You didn't tell me accurately. We're not going to rescind your policy, but we're not going to pay for your cancer treatment you just took. See, that would be an adverse benefit decision. Those things would be appealable. California, we're already doing that. No change for us. Obviously, this applies, no, not obviously, but this does apply to grandfathered plans also. Retiree reinsurance. This is a great one. The deal was this. The machine was built. The goal was to make sure employers who were currently covering their retirees just didn't dump them all into the street before 2014. When 2014, everybody can buy their own policies through exchanges and stuff like that. So they wanted to make sure that the employer kept covering these older employees. Got it? That was the plan. So what they said was, as these limits go up, it becomes more costly for you, what we'll do is the federal government will reimburse your company some of the costs for these retiree programs. They have to meet certain standards and applications and all that sort of stuff. And that the reimbursement will run out in 2014 when the new law kicks in and everybody gets covered, or until the money runs out. You see, we built this machine, we aimed it at a really good goal, and guess when the money ran out? 2 months ago. So if you got somebody who's already in the program, God bless them and good for them. But if you're looking at this or you hear about this and you say, hey, I've got a retiree group that's part of my current group plan, it can be small group, large group, doesn't matter on that, just have to meet the criteria. We can make application and maybe get the money. The problem is they're not taking any more applications because there ain't no more money. By the way, this is another learning lesson. You have to certify that you're able, and early, by the way, this could also be for early retirees down to 55 years of age. But as we said, we're already out of money. The lesson on this is when we start to talk about exchanges in our fourth class, and we talk about government backing from the exchange if California goes upside down, the government only supplies the money until there is no more money. And the beauty of it is, people always say to me, Don, you're rather sanguine about us staying in business. Well, I got a whole bunch of logical reasons why I think we'll stay in business, because we are absolutely needed. But here's the best logical reason. Are you going to vote a tax increase to yourself in the state of California if the state exchange needs more money and the feds can't give it? You going to do it? We're not willing to do it right now. We're already 20, 25 billion in the hole. What do you think it's going to be by 2014? If you won't do it, the feds ain't got it, what happens to that system on the state level? Yeah, goes bankrupt, has to raise their rates. If they raise their rates, what does that do for us in the private marketplace? Other possibility is start dropping benefits. And then what happens again? You see, there's very level-headed people in this industry nationally that recognize they intend to keep you in business because you've heard about what happens with the Greek society when suddenly things aren't working right and you got people in the street. Imagine a system in which health care can no longer be afforded. We can't afford the taxes. The federal government doesn't have the money. State doesn't have the money. And you don't exist. There's no other option. What do you think would happen in downtown LA? Yeah, people know that. Even the most hardcore socialist thinker in this process realizes there's got to be an escape valve, and that's us. What we're going to discover is we are going to use the fact that they want to keep us in business to get better at our business, and frankly, those who survive will be making more money, not less. And that's a reality, and you're going to see that by the end of these 6 courses. But that's my first argument for why we're doing these classes. You're going to need it. Okay, what about these temporary high-risk pools? Again, a machine that didn't work very well. Goal, great. Insure people who have lots of sickness and can't get health insurance. We do that here with Mr. Mib. Well, the high-risk pool was designed for the same kind of person that goes to Mr. Mib. They must be uninsured for 6 months prior to applying for the coverage. Wait a minute. So if I'm a Mr. Mib now, even if I'm convinced the federal health care risk pool is better, I have to drop my Mr. Mib for 6 months. The reason I'm in Mr. Mib is I'm sick as a dog. I'm not going to do that. So the machinery that's built is literally going the wrong way. Good goal, just can't work. Now, if you've got somebody who can't get into Mr. MIB because the lines are filled up, and that does happen, well, then a high-risk pool from the feds is better than no-risk pool from the feds. But the cockamamie thinking as to how this part of the machine was built suggested that in the first year of this program, nationally, we would have 100 to 300,000 insured in the high-risk pools. What we ended up with was, right now, 10 to 12,000. We didn't even get a tenth of what we thought because the machinery, while admirable in its goal, isn't working right. And take a look why. Out-of-pocket maximums on the federal form, 59, 50, and 11.9. Whereas the Mr. Mibs of the world work with sort of a quasi-HMO, PPO kind of pattern where you never get to those kinds of numbers. Not possible. So the bottom line is, even though the premium cost was going to be no more than 35% of the plan, in other words, an actual value was set on the plan, and the premium to the person coming into the plan was paying 35%, because it did not have the heavy managed care elements that we have in the Mr. MIB and in our private marketplaces. Because it didn't have that, the premium actual value went way high. The 35% premium was no particular bargain. Yeah, just wasn't worth it. Didn't work. That's happening all over the country. However, as in most cases, they were so afraid of us. See, one of the great canards of the world was that the reason the HIPAA in California failed was that all of you dumped bad business into the HIPAA. That was the claim. It was absolutely not true. It was not provable. Categorically a falsehood. But the people who just don't like brokers, that's the line they're running with. So this law put in an anti-dumping law. Now think about this part of the machinery. You create a high-risk pool so that people who are really, really sick go to it. You then create a rule that says, if you help this really, really sick person go to the pool, you're dumping bad business into the pool. Wait a minute, that doesn't make any sense. Duh. When you start to think about some of this stuff, when you first read it, it kind of reads like it's a little silly. And then when you listen to me, you realize, that sounds a little silly. And then as we keep talking, you realize, no, this really is silly. Yeah. State-based waivers. We talked about Maine got a waiver. The states can apply for a waiver, particularly on the basis of annual lifetime unlimited benefits. They also can do it on the case of medical loss ratios. Those are two big ones they're asking waivers on. The states can apply for that. Maine, for example, on the MLR has been granted a 65%. So to understand, in case you're not aware, medical loss ratio says if you collect $100 as the carrier, the rule is you have to pay $80 out in certain circumstances to the doctors, hospitals, and for the medical care. In other circumstances, you have to pay $85 out. Maine's primary carrier was only paying 60% out. In other words, they were keeping 40. Now, in this state, most of our carriers, even before we started monkeying around, we had a 70% law in this state, have had it for years, and most of our carriers are working within that like 72 to 82% range. I mean, that's where we typically are because of managed care. Maine was only paying out 60 cents on the dollar, which means their carriers were making a lot of money. Or maybe not. When you actually start to investigate it, what you discover is Maine is a very rural state. And so the bulk of the population is very difficult to administrate, to sell, etc. So they've got a large cost factor that isn't part of the medical care. So what the state realized was if they forced their major carrier to go from 60 to 80 or 85 overnight, the carrier just said, we'll leave the state. And that will leave 60% of your people uninsured. And so Maine applied, and the government agreed to ratchet them up 5%. They'll probably incrementalize them as they go along. Nevada has been granted a 72% level. New Hampshire has 3. They're phasing it in each of the next 3 years, 72 to 75 and then to 80. So Florida has applied, and lots of other states are also applying. We'll just keep you up to date on what they're. Are we applying for a waiver on MLR? No, our insurance commissioner does not believe we need it. And quite candidly, a lot of our carriers, you know, if you really talk to them privately, they'd say we're probably pretty good at the 80% level. 85 maybe a little tough, but 80 we're probably pretty good. All right, what else? Class, Community Living Assistance Services and Support Act. Class. What this basically is, it's to purchase non-medical services such as home health care and adult day care for your future, if you will. Think of it as a long-term care type of product. Enrollment starts next October. Yeah. Benefits don't start until 2017. You say, wait a minute. Remember how they had to get the budget balanced? They had to do the PPACA had to be balanced. So they're projecting out enormous sales in this product, which those of us in the real world know ain't ever going to happen. But they're projecting out enormous sales in this product so they collect 5 years of revenue before they pay anything out. That helps balance out the costs they're losing somewhere else. That's just the way politics works, folks. Here's the best part. As of this point, we really don't know what the benefits are going to be in this plan. We assume that by the time they ask us to enroll, they'll tell us what the benefits is, but I wouldn't hold my breath on that either. Voluntary payroll deduction. If an employer agrees to put the Class Act into his place of business, and he's not required to, if he agrees, every employee is immediately entered into it. No forms, no nothing, and payroll deduction starts happening. That's important for you to remember, because as Craig just said, the employee has to then go to the Human Resources and opt out. Think about, yeah, opt out. They have to manually opt out. Think about if we were allowed to sell our insurance that way. Okay, group life. All you people are covered. We're taking it out of your plans. Yeah, exactly. We would literally go to jail for it. But hey, the guys who run the jails get to make the rules. So, okay, what else we got? Medicare drug. Most of you know this one. The Part D hole, as they called it. Last year there was a rebate. If you got into the hole and were spending money, you could get up to $250 rebate from the government for the cost of your drugs spent in the hole. This year, oh, by the way, they would track it and then send you the money. This year, they're actually discounting when you get inside the hole. The drugs become 50% cheaper on brand and 7% cheaper on generics. What else do we know? 2020, the donut hole disappears. There it is. See, disappeared. By 2011, meaning this year, premiums for the Part D are adjusted for incomes, $85,000 on individuals, $170,000 on joint filers. So what you pay varies based on your income. Wellness was added to the Medicare product. That was a nice advantage in one sense. You now get free checkups, wellness programs, including screening that formerly wasn't paid for under the programs. So that's an advantage to our seniors. Annual wellness business, screening for all that sort of stuff. No co-payments or deductibles for that preventive care. However, federal subsidies for Medicare plan advantages will be eliminated. What that basically means in real-world terms, if you're making your living in Part D Medicare, you're probably going to need to shift your marketing and sales, because by probably well before 2020, it will eventually just disappear. You know, in some areas of the country, it's already disappeared in all candor. So you need to be aware of that. There'll be other opportunities to sell, but it's probably not in the Part D. What's in process? Well, you remember this one? You were required to send out 1099s. Actually, this is not a 1099. That's oh, yeah, it is. Yeah, it is. You were required to send out 1099s to any vendor who you did $600 of business with. That was part of the machinery that made no sense at all, but what they were looking for was new tax revenue to help offset things. That has been repealed, so that issue's dead. Other things that got repealed. You may recall, if you were paying attention, dependents coming back onto their father's plan or their mother's plan actually had a taxable event here in California. We were supposed to be paying taxes on the value of that additional health care. Our tax codes recently got repealed, so that was repealed, so no problem there anymore. This is the good one. Employee W-2 statements are going to require us to post for informational purposes the cost of the value of our health care for each employee, and the government absolutely positively swears it's only for reporting. It will not eventually move up here into the taxable boxes. So, not yet. Yeah. How many of you guys did you realize that you were actually had your employees were supposed to be tested for discrimination of highly paid employees, what we call HCs, highly compensated employees, and you were supposed to start testing last December. Now, years and years ago, there was a thing known as Section 89. Anybody remember Section 89? There we go. A couple of the more senior gentlemen. Section 89 was this grand design to test fringe benefits to see if the highest paid people were being given some kind of special advantage, and if they were, to tax them differently. So the IRS came out with these codes, and after 18 months or 2 years, I forget what it was, we all scrambled, talked about this, tried to learn it. After 18 months to 2 years, the IRS said, this is so complicated, we can't do it. Never mind. They just withdrew it. Now, in the infinite wisdom of building this machine, the Congress decided to tell the IRS on March 23rd, figure out how to do Section 89 under a different name by December. And the IRS said, what are you kidding? We went this 2 years ago, we didn't get it done. And so in December, in the middle of December, they simply said, we're going to delay what we call HCE. But here's why I'm presenting it to you. The thinking at this point, there was public commentary and presentations to the IRS commissioners in March. They took that public commentary, they shut that down, and went back in to start studying how to do it. The current belief is that they'll come out with regulations sometime probably this fall that would be effective January 1st. That means 5 months and some odd weeks from now. If you've got plan designs which benefit a highly compensated employee, they could be subject to enormous fines. That also means, just for example, if those rules come out in November, and you've just renewed the case with this highly compensated employees at all sorts of different kinds of benefits, et cetera, that would mean you'd have to redesign the plan and re-roll everybody by the 1st of January to avoid the penalties starting on January 2nd. So what I'm suggesting is, we know this rule is coming. There is some slack as to what they're going to mean. I'm going to talk about that. But we need to start thinking about employer groups right now who may be getting themselves in trouble and may simply not have enough time to get out of it in time by the time the rules come in. It's supposed to be this year, but we're guessing it'll probably come out with rules. And by the way, we don't believe the IRS is going to go retroactive because, frankly, Congress just wouldn't tolerate that sort of thing. Grandfathered plans are exempt, which is one of the big reasons people want to stay grandfathered. If I got a small family company, 5 of my highly compensated are family members, I've got 40 people out on the floor of the factory, and I've got a really rich set of benefits over here for me and my family. That's why I started the business. It's my reward for being the owner. Well, I may suddenly find out that January 1st, everybody out there has got all sorts of fines that are going to be run at me because of this 2-tiered plan. Yeah. Here's the penalty. $100 per day for each individual discriminated against back to the date of the discrimination. Now, let's assume the law starts 1/1 this year. If you've got a plan out of whack and you suddenly decide on December 15th it's out of whack, I'm sure all the carriers will bend over backwards to help you find a new plan and get it enrolled by the 1st. Ain't going to happen. You think about that. December 15th, you realize starting on the 2nd, $100 a day for each employee on the floor until you get that plan rewritten. What's going to take you, 3 months to get it issued? You're lucky, too. Probably 3. That's 40 employees? $4,000 a day for 3 months? That's going to be wicked. So my suggestion is going to be, we need to look at obvious discrimination, and I'm going to clearly say this. Let me give you a couple examples first, because it may answer the questions before you ask them. If I've got one plan, which was exemplified in Ontario, in which 4 doctors own the medical clinic. They have a huge set of benefits, 100% paid by the clinic operation, however they're organized, LLC, whatever it is, 100% paid. But all the staff gets a $200 payment towards their health care, and that's it. One doctor, he's about 28 years old, and the office manager is about 63 years old. Her premium is probably 3 times his. His is 100% paid. She gets $200 for hers. Does that sound like discrimination? Under highly compensated? Yeah. That's pretty easy to understand. Now, if your question is, you got 3 tiers. One tier is a $20 copay, one tier is a $40 copay, and one tier of HMOs, and one tier is a $500 PPO, but every employee gets to pick whichever plan they want freely and buy up. Does that sound like discrimination? No. Probably not to me either. So somewhere there in your question, there is a detail which it gets so close until we get the actual regs, we're not going to know. But the ones I'm worried about are the ones that are clearly, unequivocally, we got one plan over here for the management. The only person who can get it, all the floor people are on the lowest level Kaiser plan. All the people over here are on the richest Aetna plan. And then they've added on top of that a concierge service to take care of all the executives if they have any medical care needs. And then they're paying 100% of it. You think that's going to pass highly compensated discrimination? It ain't going to pass. It's going to fail. And logic tells you that. So if your question is, here's a specific, just answer the question yourself. How far apart do the benefits have to be before your own judgment says, I know that's going to be a problem? Regulations, public comment got closed. As with the other HCE categories we have to do for benefits, the 5 highest paid officers are part of the HCE category. Okay? So if you're in the 5, you're included. I use the word stock, and I want to be advised. I use it simply because it's easiest to say it. If you own 10% of the company, whether it's a stock company or however it's organized, if you own 10%, you're part of the HCE class. Okay? You could be low paid, but if you own 10%, you're part of that class. If you're in the top 25% of the highest paid employees. Okay? So in a case like Ward & Brown, we have 1,100 employees across the country, so 300 of us is in the HCE class. So you can imagine a very large company like that would obviously equalize out the benefits because it'd be too easy to get caught in terms of that one. Exclude it. If you've only worked for the company for 3 years, so your newest hire makes the most money, you're okay for that first 3 years. If you're younger than 25, in other words, you started your own Facebook, you're about 19, you've already been a bazillionaire, and you're okay. Anything under 25. That's the Facebook exclusion, see? Part-time or seasonal employees. So, for example, you have an engineer in our aerospace, or you have an actor in Hollywood who ends up being the highest paid person or a lighting person. That would be exception. And, oh wait, how did that come about? Politics, my friends. Many of you know, if you've worked with a company with a collective bargaining agreement, the people on the floor with the collective bargaining agreement have a huge set of good benefits compared to the poor schmuck that owns the company. I mean, the people that own the company have usually lesser benefits than the people in the collective bargaining unit. That was exempted because they supported the right people in the right place for that law. Essential benefits. They're expected to be released. The definitions of essential benefits expected to be released in September. I wouldn't hold my breath on that. But that's what they say. The essential benefits will be the basis for the mandate for employers. In other words, employers with 50 or more will have to provide a policy that covers the essential benefits. Providing a policy that does not cover the essential benefits has not met the mandate. They're liable for the penalties. Okay? So there'll have to be some benefit changes there. Obviously, these essential benefits are designed to be reviewed annually by HHS. Preventive and wellness definitions, they have said that whatever changes occur between essential and non-essential benefits on wellness and preventive will not be effective immediately, but will allow the carrier to work it in within the 1-year change of contract. Okay, so that little bit has been solved. Obviously, we already know over-the-counter for HSA, FSAs are no longer allowed. MLR, medical loss ratios. Remember we talked about that a second? What it basically says is, if you're in a large group, the carrier has to give 85% of the money for health care. If you're in a small group or an individual, the carrier has to give 80% of the money to health care. And if the carrier doesn't do that, if at the end of the day, Mr. Blue Cross gives out 78%, he's 2% under the MLR, the 2% returned as a rebate to the policy holders. Okay? That's how that's going to work. Again, like I said, we're going to talk about this more in the 6th class. It's not as draconian for us in California as we think, and we actually may have a national solution perking up through the Congress right now. That national solution is going to be H.R. 1260, which has been approved by the NAIC task force and has been signed on by 41 co-sponsors in the House of Representatives, both Democrats and Republicans. And what it basically says is, when you calculate the $100, add in the $8 or the $20 or whatever it is that we get as commission, add that in on top and do your calculations for MLR just on the 100. If that law goes through, our commissions are protected. By the way, if that law goes through, any person who's never paid money to a health underwriters organization ought to be ashamed of themselves, because the health underwriters organization is the one pushing and making this thing happen. That's a fact. Okay? 2012 starts at $1, later rises to $2. additional money will be found. It'll be a tax. It'll probably be billed by the carrier to your employers, and that money is going to be used to pay for comparative research effectiveness. What the PPACA machine is trying to go at is, can we get some money to research what's the best way to treat a heart attack, to treat lung cancer, whatever it may be. That money will be used for that. Groups that are self-insured, people working self-insured, when this comparative research stuff comes out, they'll set some standards of what's a sort of a good treatment, what's a bad treatment, etc. And if you're self-funded, you're going to have to produce your own reports in that way and deliver it to your plan participants. That is going to be wicked. We don't know what it's going to look like yet. We'll keep you informed. Another nightmare. This one we already do. The law requires by 2012 that we give some sort of summary report to our employees that are covered. We do that right now in California all the time. It basically looks like a Ward and Brown Quotomatic report if you really want to look at it. We do material benefit notifications now. The federal law requires 60 days. We've already got that pretty much in California. This law is aimed mostly at other states, but the only way we would be impacted is if they change the definition of what is a material benefit change. That's not yet been defined. It'll be defined in 2012. If they say any kind of change must be notified, then we'll have more notification requirements. 2012 on individuals, flexible spending accounts get capped at $2,500. Class Act comes into play, and as Craig mentioned, it will be automatic. If the employer takes it, you must manually opt out if you're the employee. We already covered that. Higher taxes. You figured this is going to happen, right? Higher taxes, almost a % of additional Medicare hospital insurance for 200,000 and 250,000 filers. Self-employed people will not be able to deduct any portion of this tax from their activities. And there'll be a new Medicare contribution up to 3.8% for the highest earners of adjusted gross income. What else we got? 2 other tax increases. Those of you who know enough about your own taxes, you have a Schedule A. It itemizes your deductions. Right now, if you have more than $7,500 out of a $100,000 income, then above that, above 7.5%, you can start deducting from your itemized taxes. Okay? So if you have $200,000, you have to get $15,000 of medical expenses before you can deduct. That 7.5 changes to 10% starting in 2013. Some of your high income earners with particularly high deductible plans or self-insured plans or something like that could get trapped where they're not going to be able to write off some of their health care. Individuals of 65 or older get phased in until 2016. What else? Here, this notice is going to become important by 2013. Employers, and we'll work with you on some formal notifications, we'll probably get it out to you, but you'll have to inform the employees that there's a thing known as an exchange starting in 2014, and that the employee is going to have a right to go to the exchange even if he's covered at work, if that's what he wants to do. So that notice will be coming out. The notice will require to include the following: an explanation of the exchange, a description of services in the exchange, how the employee may contact the exchange, an explanation that the employee may be eligible for a premium tax credit in the exchange, and obviously a notification that he will no longer get his employer's contribution if he goes to the exchange. By the way, somebody once asked, how will the state know what I'm doing in my private health care plan in my little group? Because if a person leaves your group and calls the exchange starts asking all sorts of information from that person before they're allowed to process into the system. Because they're required to ask the information, and the information that's gathered from that individual goes to the IRS, to the state agencies, to HHS, and everywhere else. That's the job of the exchange. Part of it is, because most of us don't realize this, the exchange, and we're going to cover this in Class 4, the exchange is required to sort people when they come in under this ruling, so that if a person is eligible for, say, Medi-Cal, they get moved to Medi-Cal. They're not purchasing it from the private side of the exchange. They're moved into the state system. So that's how the state is going to collect all that information on all those employees. So if you've got employers out there who think they're going to be able to hide the fact that they're not paying for people's health care, whatever it may be, they got another thought coming, because everybody going into that exchange is going to be reporting stuff. Secondarily, by 2014, when individuals are mandated to show on their tax return that they got health care, I don't know what that tax form is going to look like, but I'll bet you money it isn't just yes or no, check the box. It's going to happen. They didn't hire those 26,000 IRS employees just to look at yes or no. All right, what else have we got? 2014. Coverage must be sold on a guaranteed issue. We already have that in California. That's different from other states. This may be problematic for some of our, particularly our managed care people, where no medical questions will be allowed on the application process. Our biggest concern, of course, is managed cases, large case transfer between carriers and that sort of thing, medical case management. We'll probably have other ones. Small group will be defined as 1 to 100. That's good for us who are working in the 50 to 100 size, because the 1672 would apply. However, the state can opt to delay till 2016. Our insurance commissioner would prefer they get into that small group category, so we'll probably have an advantageous situation if we're competing in that 50 to 100 market. Individuals and fully insureds up to 100 lives will be priced under the community rating standards. Now, a lot of us think community rating standard is like one rate for everybody, and that could be one interpretation. But what PPACA is talking about is a age, location, family composite type of banding, the way we pretty much have under 1672. We're not going to see a lot of differences, but there will be a couple. For example, the premium differences will shrink on age. Right now, our 20-year-old, maybe he's at 100, and our 62-year-old, he may be at 1,000. So we're looking at about a 10 to 1 spread right now. Now, the good news is under PPACA, the carriers will have to compress that to 3 to 1. And so we're certain all the carriers will bring the higher rates down so that they have the 3 to 1. You guys don't? There's a selling opportunity here. You think about it, because it is not going to go 100 to 1,000, 100 to 300. It's going 100 up to 300. The bottom's getting raised, not the top being taken down. So the bottom line, by the way, they'll also be allowed tobacco. That'll be new to us. Family composite geography, we do that already. Geographical regions, we already got that in this state. Experience rating will be prohibited. And that'll be good for those groups like in that 85 category that get whacked sometimes with their own experience. So we'll have a little advantage there. Wellness discounts will apply. All right, guaranteed issue without the right, we already covered that one. What do you need to know? Exchanges have to be operational by 2014. SHOP is going to be exchange. Somebody asked about group sizes. SHOP is going to be an exchange set up for small group. And it can be allowed to operate with 100+ groups starting in 2017. Okay? So if you believe it can survive that long, actuarially, then come 2017, it's available. I don't believe that. It's primarily designed to fulfill the individual mandate. That is, where somebody's an employee of a sweatshop in a building underneath one of the overpasses, and they're sewing hems, and that guy ain't offering health insurance now, and he's not going to offer it in the future, never will. That employee would go to the exchange to get their coverage to fulfill their obligation under the law to have health insurance. Okay? That's what they would do. What else? There'll be a requirement that everyone carry some minimum level, what they call the essential benefit level. People will be exempt to fines except for the very lowest income if they don't carry insurance. What we're going to see is failure to carry will cost you either a percentage of your gross taxable income or a flat dollar figure depending upon your income, and the percentages will rise up. What we're going to see when we do our 5th class, which is the math class, we're going to look at how those penalties will create people to make a decision whether they pay the tax or whether they take the health insurance. And that's a real issue you're going to have to deal with. We'll cover that in the math class. Other possibilities. Employers of 50 or more, and I mentioned right at the beginning, 50 doesn't mean what you think. I can prove to you a 30-life group is going to be required to do it, and an 80-life group might not be required to do it. It depends upon how you count the numbers. And we'll do that in the math class. We'll count full-time and part-time employees. Certain seasonal workers will be involved in this count in a certain way, and full-time will be categorically defined across the country as 30 hours per week. So no variation from state to state, 30 hours per week for this law. There will be penalties for failing to not have coverage as an employer or failing not to have affordable coverage. We'll look at the math of how this works, but just to prepare you for the math in that 5th course, if an employer does not have a plan Generally speaking, he's going to be taxed at $2,000 per employee in the company if he does not offer a plan. If he does not offer an affordable plan, he's going to be taxed at $3,000 per person that is subject to this unaffordability. So the count's going to be really different. We're going to teach you to work through the math of how it works. It's conceivable that an unaffordable plan could actually cause a guy to pay more taxes and more penalties than the no plan. So it just depends upon the math. We'll carry you through that. And people who are the lowest paid employees who go to the exchanges will be eligible for credits and supports and subsidies. And we'll work all those details. Waiting periods will go to a single no more than 90 days period. Auto enrollment. Those of you who are working in 200 lives groups by 2014, you apply for your job, you go to your first day in your job, you're on the health care. Payroll deduction starts. It's automatic enrollment. It's like the Class Act. You would then have to opt out manually in a larger group. Waiting periods will still apply, but obviously there's going to be a maximum of 90 days. Employees may opt out if they have another source of coverage, but that's going to be an opt-out, and you're automatically opt-in. And when we start that, Cadillac tax, remember that business about the unions having a better benefit? Well, starting in 2018, they will be taxed because of those better benefits, if those better benefits still exist. And let me do this last part verbally real quick. So what? What we learn right here that we can start using in a prospecting event tomorrow. Somebody says to me, I don't need to talk to you. I want to visit with you. You're my prospect. I want to take you to lunch. I want to call you on the phone. I want to drop in and see. I want to write you a letter, an email, a pamphlet, whatever I want to do. And he says to me, I really don't need you. I got a great broker right now taking care of me totally. And based upon what I've learned in the last hour and a half, I ask him, I'm curious, has your broker informed you of the necessity of starting to collect the healthcare cost information in order to start gathering it January 1st, 5 months, 2 weeks from now, for the W-2s you're going to release in the spring of 2013? If he has told you that, how did he tell you to calculate the value that you're supposed to report? Okay? My guess is no broker has done that. You say, what's the impact of that? He says, so what? What do I need that for? Well, for starters, if a guy works for you for 2 weeks in January and then quits, do you have to report his? Yeah. You're going to have to calculate out the value of the health care he got. Secondarily, if he quits, he has a right to ask for an early W-2, not wait until the spring of 2013. You may have a problem on your hands. You may be trying to play catch-up. We're not going to do it today, but each of you is thinking, well, that's easy enough. The value is planned. I just look at the premium statement the carrier sends me. Not that easy. There's all sorts of other things that he may be getting that is considered value for health care that have to be included in the costs. It's not just the premium, but we're not going to detail with that in course number 5. Another opportunity. If a guy says to me, no, rather you. You're sitting out here, it's 2014, right? 2014, January 1st, your groups are coming up for renewal. Who's getting the steepest renewals January 1st, 2014? Think about it. Nope. How about which group gets a higher renewal? The group made up of all 56-year-olds or the group made up of 20-year-olds when the composite? You may want to start thinking in terms of your own business of where you're prospecting at. Because if you think you got blasted by that young group for giving them a 16% rate increase this past year, that's just due to medical cost, what do you think is going to happen when that composite comes up? Unless you're naive enough to believe that the composite is coming down. I don't believe that. So I may be making some decisions in terms of my prospecting, and I sure as heck, starting going into that 2014 period, am going to be alerting the youngest companies I've got to expect some changes. They need to start budgeting that probably sometime in early 2013 if you really think about the thing. Okay? My broker's doing just fine for me, no problem. What has your broker told you about highly compensated employees, and has he told you that the likelihood is that the new tax codes will be affecting you 1/1/2013, 5 months, 2 weeks from now? So what? What do I need that for? Go away, you annoying agent. Well, let me explain why. Because if your plan is out of compliance enough that you end up with a discriminatory act, your penalties of $100 per day per employee could start on January 2nd and run for every day until you can get that plan design changed and implement it. And most of us know we're lucky to get that done in 60 days. Has your broker talked to you about that? Now somebody says, do I really think there's that many people who are going to get caught in that? That's not the point. I'll give a guy a Rolex watch if he's got a big enough group to let me have 5 or 10 minutes with him to prospect with him. I'll take him to lunch. I'll spend $100 on his lunch. The goal we have as salespeople to get those 5 or 10 minutes, to get our foot in the door. And if I can use something I just learned about this act to scare the bejeebies out of the guy so he at least says, you know, actually my broker didn't tell me about that, and frankly, I hate my broker, I haven't seen him in 6 years. I just told you I had him so you'd go away. They do that, don't they?
Oh, yeah.
They're like children. We got to get them to understand, look, something good or bad can happen to you. If you give me 5 or 10 minutes, we'll find that out. And once we start talking to them, then we're looking at getting the quote and running a comparison and seeing if even if nothing bad is going to happen to this guy, we may find other ways to save him money, improve his situation, and frankly, make him a client. And that's what we're all in the business for.